So welcome everyone to the Rediscovering Your Child Pediatric Brain Injury event. We have 5 lovely panelists here to talk about pediatric brain injury in a wide range. I am Marissa Rogozinski, and I'm your moderator tonight. And I also am a survivor of pediatric brain injury. My brain injury was when I was 17 years old, so the later end of it, with a softball injury. Let's see. So as the audience, throughout our presentation, you'll have the opportunity to ask questions that are pertinent to what we're discussing. If you have any general questions for our panelists, you can ask them in our question section that we have at the end of our discussion. Other than that, after we have cupcakes from Sweet Frostings and coffee and tea and hot chocolate and that you guys can have. As well as, if you haven't yet, we have a $100 door prize that you can enter to win at the end of the night. So feel free after the panel is done to stop by the check-in table and do that. And we'd like to thank Community Minded Television and the library for the recording and the audio that we have going on. So we're going to start off by having each of our panelists introduce themselves, give us a little background, and then we'll start. So whichever end would like to start.
I'm Shelley Abris, and I'm a child life specialist at the Sacred Heart Children's Hospital. I cover the pediatric intensive care unit, and I see pediatric consults at St. Luke's Rehabilitation Institute.
My name's Erin Gilly. I am a pediatric physical therapist. I got my doctorate from Eastern Washington University in 2007, and I have practiced in outpatient pediatrics schools and have been at Sacred Heart for a little more than 7 years, working on general pediatrics, the pediatric ICU, and pediatric oncology units.
I'm Sherry Burrell, and I'm an occupational therapist. I spent the first 7.5 years working on the traumatic brain injury unit at St. Luke's Rehab, and I've spent the last 13 years in pediatrics working for Spokane Public Schools. I'm also nationally board certified in professional teaching standards for students with exceptional needs.
My name is Alicia Hagee. I'm a neuropsychologist, and I work at St. Luke's on the brain injury and the spinal cord injury units.
My name is Alicia Furman. I am a physiatrist, which means I'm a doctor who works with people who have physical or cognitive impairments, such as brain injury. I work both at St. Luke's and over at Sacred Heart Medical Center.
Perfect. Thank you for coming again. So we're going to start off with our general question for the night is going to be, how can brain injury impact the life of a youth or adolescent? One of the first questions that we can start off with is, what are primary issues with the detection of brain injury in youth and adolescents?
We can kick it off. We'll just go down the road this way now. I think primary issues with detection, particularly when we're talking about milder traumatic brain injuries, are that the symptoms can sometimes be vague. So maybe a kid has had a head injury, but they didn't lose consciousness, and they might have a headache afterwards, or they might not really have any symptoms at all initially, and they might develop symptoms later. I think particularly depending on the age of the child, that can also really affect symptom reporting, because younger kids may not know to tell mom or dad or a family member that they aren't feeling good, or that they're feeling like the room is spinning, or that they feel like they have to throw up, or they just may not have as much awareness to know that that's going on. Those would be kind of the initial things that I think about when I think about why are we missing brain injuries as a diagnosis.
Another tricky factor is,
I just had a thought on that. How do you teach a child what normal feels like? I wonder if that's part of being able to detect, because they may not know what's different from normal.
Sure, yeah, absolutely. And it's one of the things about that is it's kind of hard to teach normal. It's something that as kids' brains develop, they generally begin to develop a sense of kind of what their body is and what that feels like. But I think sometimes it can be helpful to even just check in with a kid and say, hey, I noticed that you hit your head on the playground. do you feel different than you did before you hit your head, or you notice anything different, and ask them to describe it as best they can.
Another difficulty with detecting brain injury is that the situations that kids are most likely to incur a brain injury, things like sports, they may be apt to minimize symptoms. They want to get back out, back onto the field, and so they may deny that something's going on, even if it is. Another tricky piece can be that injuries can be additive over time. So a child can sustain an injury that they've sustained before and were fine, but it can affect them differently this time. And so keeping that in mind and watching that over time and being really familiar with kids. And then also having empirical standards for teams to be looking at, to making sure that as a community, we're tracking kids and helping them be successful.
One of the things I notice is that oftentimes the signs and symptoms of a brain injury also sometimes mimic some of the typical adolescent behaviors, the sullenness, the moodiness, the sleepiness. And so it's often hard to tell, well, did he have an injury? Did he not have an injury? And oftentimes kids won't report that they've had an injury because they want to get out and play. Or it could be the cumulative effect. It might be, they took one fall and it wasn't that bad, but they get right back out on their skateboard and they take another fall, and then suddenly they've had 5, and the behaviors are just getting worse, or the feelings are getting worse. They're nauseous, so maybe it's just them coming down with the flu. So it's tough because the behaviors or the signs and symptoms that we see can mimic multiple other things, or can appear developmentally appropriate too.
I think some other factors can be that people don't know what types of injuries can cause a brain injury or concussion. Like, for instance, I saw a patient who was in a rodeo event and fell off of his horse and broke his leg. And everybody said, well, he didn't hit his head, but he hit his body on the ground with enough force to severely injure his leg. And that type of impact just on your body can have repercussions on your head. And so sometimes when we're looking at the most urgent emergent thing, some of those more subtle things can be overlooked because there's not anything that shows up on radiographic imaging that shows, oh, there is an injury to the head that we can see on a picture. And then when you're factoring in pain medications and recovery from a big event like a car crash or another injury, that sometimes those things kind of get filtered to the back and they don't get picked up on until later. And then somebody says, oh, well, maybe there was a head injury that occurred at that time, but it's kind of gotten lost along the way.
And I think also, speaking about teens and maybe not reporting it or not knowing what to look for, same with infants and toddlers, they can't speak what they're feeling. So kind of trusting your gut as a parent or the caregiver, you're the expert on your child. So if you have that gut feeling, don't be afraid to go in and get a second opinion if it was minimalized the first time.
Yeah. So each of you work with a child in different stages of their brain injury. Some are right as soon as it happens, others are the progression through it. What are some primary learning challenges that youth or adolescents with brain injury may encounter, specifically perhaps at the stage that you see them in the long term, and what potential strategies maybe do you utilize in those situations?
So many times I'll meet the patient right after the injury, be it in the intensive care unit, so they have either had the trauma or it's progressed to a point where their health has declined. So many times I might not even be able to speak to the child if the child's unconscious or intubated. In those cases, I focus on building rapport with the parents so they can teach me about the child. And then kind of choreographing the environment to meet the child where they are. So if they have sensitivity to noise, lighting, anything of that nature, we'll provide a low stimulation environment so that way they're not getting overwhelmed, or we're giving them a chance for their brain to heal while they're in our facility. And also working with with adolescents, or not the adolescents, but with their siblings when they are, when the child's not available, to help them understand what's happening to their brother or sister.
I also work with children in the hospital setting, so these are kids that we know have had an event. I think that, like we just talked about, the tricky thing is knowing when they've had an event. So in the hospital, when somebody has had an injury and we're looking at whether or not they have a mild brain injury or they have a more severe injury that we definitely know has brain involvement, I work with Shelley in the ICU, so therapy and child life work with the nurses and doctors pretty closely to help minimize stimulation to their brain so that it can rest and recover. And then providing a lot of education to their parents and family members on ways that they can support their healing, whether that be having the permission to remind people to keep the environment quiet and low stim, telling them it's okay to tell visitors to wait until they're at a better phase of recovery. And then on the less severe side of things, when somebody's not in an ICU, maybe they had a sports-related concussion and came to the hospital and got admitted for observation. We do lots of mobility-related things like checking balance and safety, monitoring symptoms like headaches and vision changes, and again, just providing lots of education to their family members about things related to head injuries that they might see at home and in their transition back to school, and how to go about getting follow-up for their child.
A lot of the things that we see in the school district are, the cognitive aspects. How does it impact their education and their ability to learn? And it's not always finite. You can't always say, well, they have memory problems, because it may just be holes in different areas that were damaged, that they can still override some of those things. So they might not present as really having short-term memory deficits, because it's only like in certain situations or with certain things or at certain times. So that kind of becomes one of the challenges, but there's a lot of compensatory strategies that we can teach them, and study aids and study guides. But one of the hardest things too is part of the grieving process that parents are going through. By the time we get them, they're still going through that grieving process of having been through such a traumatic event with their child, and they're really struggling with, well, how do I deal with this and what do I do? And they're really encouraging them to quick get them back to school, get them back in, get as much normalcy as possible. And I really try and educate my family members on, and the caregivers, that just like any broken limb or any other part of the body that's damaged, what are you told? You're told to rest it. You're told to take your medication, ice, heat, rest, elevate, all of those things. We don't really have that opportunity with the brain. We don't get to just shut off the brain so it has appropriate time to heal. So really being conscious of that and how that might look, and allowing their child to take the time that they need, because it is going to be a longer recovery than it would be, say, a broken leg or something like that. So it's just really important to make sure that we not expect to see like a huge deficit in just one area, but that maybe it might be little bits and pieces throughout. And then, of course, how do we support that? It's different for every child.
Yeah, in the acute setting, often what I'm talking to families and patients about is the importance of structure. So if you're going to see a difficulty really at any point during the recovery from a brain injury, it tends to be in internally structuring yourself in a way that many of us don't have to think about. So things that families can be doing is creating predictability, following a schedule, externally providing structure, and encouraging children to do that. So don't jump into starting a project. Take a minute, plan an approach, and also take breaks. Don't sit and work for an hour and get lost in the process. Set a timer, and when that goes off, 10 minutes in, you're going to stop, get a sip of water, and you're going to go back and not just look at where you're at, but also how you're doing it, and is it working for you or is it working against you? And learning when to ask for help, and pulling in other adults so that they can be getting the support that they need as they are relearning new strategies and new approaches to doing tasks, because we need to rebuild different kinds of muscle memories so that they can do things successfully moving forward. And one piece of education I'm always trying to give families when it comes to learning challenges is that It's difficult with children. They are changing so rapidly, and so their recovery tends to be pretty good if you look at the numbers. But the trouble is the time that they spend recovering is time that their peers are spending developing. And so that can create a gap. Even though the child has a really good recovery and they do well, their peers were continuing on a trajectory as well. And so even though they do well, there can be a gap. And sometimes that doesn't show up for a while. So kids can function really well and look like they're not having difficulties. But as you progress through the school system, the structure that the school provides, what we call the scaffolding, tends to decrease. The expectations on a 9th grader are very different than the expectations on a 6th grader. And so a kiddo who was doing really well in middle school may start to struggle in high school, and it seems new. But the truth is, this is just a showing of difficulties that were there before. And so I'm always encouraging families to make sure that schools are keeping their eye on that. And that if an IEP or if the school was notified in some way, that's being kept in place, even if the child is doing well, so that if they start to struggle in the future, if they grow into their brain injury, that the school is aware of that and is more ready and willing to throw the resources that that child needs to be successful.
A lot of the challenges that I face as a doc usually has to do with symptom management. So a kid might say, every time I get out of bed and I'm walking around for more than 10 minutes, I start having a headache. Or every time I try to read something, I get double vision, or my eyes start hurting, or I get dizzy. So many symptoms can follow a brain injury: nausea, difficulty concentrating, difficulty remembering. And so for us, it's a lot of how do we take these symptoms and manage them, and not just throw medicines at them, but how do we appropriately allow the kid to take breaks. So like Dr. Hedgie said, if your kid is working on something, taking a break, allowing kids to have frequent breaks, especially after they return to school, they might notice that they're having more difficulty in class than they did before. And so allowing them to take breaks, allowing them to maybe have a passing period that's not the crowded, busy passing period that all the other students do, but that they have some time, maybe 5 minutes before everyone else leaves, so that they can go through the hallways and not get disoriented and not get dizzy when 100 of their peers are swarming around them. Allowing them to postpone certain high stakes testing. So if a kid has a brain injury and then they get back to school and it's AP testing time or SAT testing time or any one of the number of standardized tests that kids have to take, allowing them and talking with the school and saying, this is what happened, and I would like my child to have either a postponement of this date or extra time on these special tests or something, so that we're accommodating for kids and their brain injuries. And I think the other component that I utilize a lot as a physician is getting involved with neuropsychiatric testing. If I'm really concerned that a child has learning, either a difficulty or some kind of change in their learning style or ability after a brain injury, neuropsych testing, even though it can be long, this is multi-hour testing we're talking about, that's where we can really uncover certain impairments and then really hone in on them. So that way, again, when we're looking to schools to support kids, we can say, this is the testing that shows my child's short-term memory is fine, but his attention is impaired, and so as a result, it's not that he can't remember things, he just can't pay attention to them long enough to get them stuck in his memory so he can remember them later. And that can really help give schools, teachers, and other caregivers some tools and kind of other ways to think about how do we compensate or how do we address the issues that a kid has after a brain injury.
And recognizing that may not be a one-time thing. You may get it done the year after, and then it may be helpful to relook at that a couple years later when it's SAT time. And they're doing really well, but they do need a little bit of extra time. And so knowing that you can advocate to have some of these things looked at multiple times at strategic times and working with the care team.
Yeah. Always advocate for your child or a child that you know that has a brain injury, because generally we as providers have not met your kid before the injury, and so we're doing our best to kind of address what we are seeing afterwards. But you generally know your child better than anyone else, and you know what they normally are like, and you know their moods, or you know what they normally do or do not do. And so if something is different, I always advocate that parents and family members and caregivers advocate for their child, because they're kind of our number one resource when it comes to what has changed and what's our comparisons.
Yeah, so it would seem that across the board, it sounds like each child may be different in different aspects of their recovery, their brain injury, but there are some similarities. There are some observable symptoms that you might be able to see right away, some that are long-term. Are there a few observable symptoms that are more prominent than others that you might see more frequently in children?
I've got a slide for this that's got a lovely table on it, so we don't have to just list them in bullet points. So if you look behind me, this is a concussion study. So briefly, we generally use or hear concussion and the term mild traumatic brain injury used very similarly or interchangeably, and for most intents and purposes, they are. So this is from a high school reporting information online system. So this was self-reported post-concussive symptoms in high school athletes. So hopefully by this age, kids are pretty in tune with what normal feels like or what is normal for them, and they're able to kind of tell what they noticed after a concussion. And so the most prominent symptom was headache by far. And you'll notice on the left side is symptom recorded. The middle column is the number of concussions in this survey. And then on the far right side is the percentage, and you'll notice the percentages on the far right do not add up to 100 because kids were allowed to report more than one symptom. So that's why it looks like there's way more than 100% of symptoms here. So headache is primary, number one. After that comes dizziness or unsteadiness. After that, difficulty concentrating, confusion, vision changes, nausea, drowsiness, amnesia, and then we start getting into kind of less frequent symptoms like sensitivity to noise, tinnitus, which is a ringing in the ears, irritability, loss of consciousness, which you'll notice is only 4.6% of these concussion symptoms. And you don't have to lose consciousness to have a concussion. You do not have to lose consciousness to have a brain injury. And losing consciousness or not losing consciousness is not a prognostic indicator that can really predict what outcomes look like long term. So just because you say, well, I hit my head, but I didn't black out, but I was kind of dizzy afterwards, and I noticed that these bright lights really hurt my eyes, and all these other things, that could still very well indicate that you had a brain injury, even though you didn't black out or pass out or lose consciousness.
Perfect.
Did I answer your question?
That sure did. All right, so does
I
anyone
have something to add
Go
to
for
that
it.
too. Just looking at this chart, these, especially about the top 5, are feelings that people are reporting, and those things all put together can be really strongly impacted by your visual motor vestibular system, which is your body's balance and vision working together to keep your balance and make your eyes track smoothly. And so one of the big symptoms that I see on my exams with kids that have had head injuries is that their visual tracking is not very smooth, especially when it involves head movement and repetitive scanning. And so that's reading and writing and sports, because we don't play sports in an environment where we stand still and other things stand still. The brain's ability to process things that are moving past you and use your peripheral vision and make rapid changes in eye movement over time can cause fatigue if those things aren't working smoothly together, which can contribute to headaches and irritability and dizziness. And so that's one of the things that physical therapy looks at. And so I always recommend that if somebody has had a suspected head injury and they're still symptomatic with headaches over 3 weeks later, that they go see a physical therapist to have more of those symptoms checked out, because headaches may or may not be muscle related in origin or just because of the physical hit to your head. It may be a vision and balance related issue, which the occupational therapists probably see a lot in the schools as well.
Yeah. And Erin, not to totally stump for PT and OT here, but Washington is a primary referral state for therapists, right? So you don't need a doctor's referral
Correct.
to go to see a physical therapist or occupational therapist?
Mm-hmm.
Okay.
Yeah.
Little tidbit.
Yes. And another common thing to watch for is processing speed. So if you look at a lot of the tests that schools and the NFL are moving towards, they're basing some of their symptom tracking on how quickly you can process and split attention. So that's another common one, and can have to do with a lot of these other ones. If the things aren't happening smoothly, it takes a lot more effort and can affect other things, but feeling slower.
Awesome. Okay. So for any of you that this may apply to that you've seen, what are some potential long-term challenges that a youth or an adolescent may encounter? Whether that's they've made lots of progress, maybe as they've made little.
I think the one that I saw the most when I was at St. Luke's, and also what I see in the school district as well, is regardless of age, is the potential for re-injury. A lot of them end up with frontal lobe injuries, which is kind of our filter, and they end up with frontal lobe injuries, and then they end up continuing to participate in and engaging in more risky behaviors, which puts them at risk for more injuries, and so it just ends up becoming this loop. So really, re-injury is the biggest thing that I've seen.
I think generally when we're talking about mild traumatic brain injury and concussions, the long-term challenges are minimal, if at all, and I think that's one of the most important things that I want to stress here is the majority of people, particularly that have concussions, the data supports that most of them, the symptoms are the worst in the first 7 to 10 days, things get better by a month. Most people are back fully recovered after 3 months or so. So I want to leave or give you a really hopeful note with that, is that a lot of mild traumatic brain injuries and concussions have good outcomes. That being said, long-term challenges are generally seen with kids and adults who have had more severe brain injuries, and so that generally means on imaging, like a CAT scan or an MRI, we saw blood or we saw bruising or we saw swelling. Those generally portend that you're going to have some longer term issues, and I find that oftentimes cognition and balance are the two biggest ones, because either people are having difficulty, kids are having difficulty in school or trying to keep up with peers, or just having difficulty with balance. I mean, when you think about kids run around and jump around and climb around on everything, and generally you got to have a pretty intact vestibular system to account for that. And so if that's been knocked out of kilter by a brain injury, that can definitely cause difficulties and issues in your day-to-day.
And I was actually going to say the exact same thing. 93% of people 3 months out are doing really well from a mild injury. And I'm so sorry, I didn't see your hand. Yeah.
Can some of the symptoms like tinnitus show up later, like way later? Would you be surprised at that? Or?
I would not be surprised per se, but I think one of the other things that we didn't necessarily talk about with these brain injury symptoms is that, actually it was mentioned, they're mimickers. And so you can have, I've taken care of patients who had migraines frequently before a brain injury. And so then after they have a brain injury, they're getting headaches a lot, and we're trying to figure out what's going on and trying to assess this. And they say, well, this kind of feels like my old migraines, the light bothers me, I'm nauseous, and those kinds of things. And so I think generally, if we're attributing later symptoms to a brain injury, I would really want to rule out that it was nothing new coming on, rather than just saying, oh, that must be because you had a brain injury 6 months ago, and that's why now you're having some tinnitus or you're noticing something new. I would use the kind of what we call diagnosis of exclusion. I want to make sure it's nothing new before we start attributing it to a brain injury, particularly because things like tinnitus can be caused by medications. They can be caused by a lot of things. And so I would not want to just chalk new symptoms up to a brain injury without a more thorough investigation first.
So a follow-up question to that. Tinnitus is something I associate with external injury and advancing age. The loud gunfire, kind of exposure to loud noise.
Right.
Loud noise. So in young people who have a head injury, I know the numbers go there, what percentage is the number of concussions? Would you also be concerned about that? Would you try to figure out another cause for tinnitus?
Yeah, and I think tinnitus is a real bother in that it is hard to treat even in people who don't have a history of brain injury. It can just be hard to kind of chase down the cause. And so a lot of times then, it focuses on, okay, let's rule out kind of the scary or the treatable things. Like, are you on any medicines that could be contributing to this? Is there any other new changes that, have you had a history of loud noise exposure, and so now that's what's contributing, and you had some sensorineural hearing loss? Or is it you had an exposure to some kind of chemical or some other thing? Is there something that happened to you that could have caused this? And then if not, thinking about what are the compensatory strategies for managing it, right? So for whether that's utilizing things like white noise or music or other things to distract, because I think for a lot of my patients, and y'all chime in on this if you have other things, for a lot of my patients that have tinnitus, the biggest thing is when they are sitting somewhere that's quiet, that's when they notice it, which is usually at work trying to get something done or falling asleep. Both times you really don't want to be distracted by annoying buzzing or ringing in your ears. And so then it's sometimes just a way of managing it where we say, okay, we checked, there's nothing treatable or scary that we think is going on with this. That doesn't mean this isn't annoying and it doesn't bother you, but how can we work around that either by utilizing things like music or white noise machines or a fan in your office, something to kind of help drown that out so that you're allowed or able to go back to doing your normal daily activities, that you're able to sleep, and that this doesn't become something that controls your life.
I have seen some studies that learning relaxation or mindfulness can be helpful in the management of tinnitus for that exact reason, because the more it upsets you, typically the worse symptoms get, and then the more it impacts your life.
So I had one more question, and that is, I can imagine a child with ADHD being very hard to decipher on these things, and that it could amplify all the ADHD presentation. So would you just kind of address that combination of situation?
Yeah, and having a prior psychiatric or cognitive diagnosis before a brain injury can definitely set you up to have a worse outcome after a brain injury. I think one of the things, fortunately, is that a child who has a diagnosis of ADD or ADHD should have had some sort of testing done or evaluation done prior to the brain injury that says this is what the child is capable of or what he or she is able to do, so that they have some sort of baseline to go off of. And then if nothing else, looking at things like grades and testing and other stuff. You got an input on that?
Yeah, compensatory strategies. So ramping that up, really upping the structure, teaching kids ways to intervene for themselves, having consistency between school and home. The interventions tend to be very much the same, but again, we're relying on previous testing or information from families so that we can understand where the kid is now compared to where they were and what we can do to help that child be successful. And in terms of common symptoms, difficulty planning, difficulty organizing, difficulty putting things together tends to be common in the short term. The biggest complaint of patients tends to be difficulty with social interactions and changes in sleep. Sleep makes sense. You've got all these other symptoms going on, and sleep is kind of a tricky thing to get to anyway. But it's something we want to be watchful of and doing what we can to optimize in the short term so it doesn't become problematic long term. The socialization can be trickier. So in the short term, if you're having these symptoms, it's harder to be around your friends. You feel like you're different, people are asking you questions, maybe you're getting help that you weren't getting before. And the tricky thing is then even if kids start to get better, getting that socialization back on track can be a little bit more difficult. And so providing education for the child, for the family, for the kids who are close to that child to try to support them getting back to feeling like they're part of the group can be really, really important. And then the family setting, making sure that that kiddo doesn't start to feel like they're the patient or there's something wrong with them or the family revolves around them, that we want the family to remain a family. And we want there to be structure and support to set the child up for success, but we also want things to feel familiar too, so that the child doesn't feel like everything has changed and that's somehow their fault. And so doing that, I think in the short term, but also throughout, is really important. You kind of mentioned.
Yeah, well, an ADHD is tricky because it's really a conglomeration of symptoms. And trying to honor those symptoms and what they're seeking, which are increased distractions to help them concentrate, also can make their deficits seem greater. So it gets difficult because they're wanting more activities and more things to do, which is counterintuitive to how we would treat recovery from a brain injury where we want less. So it does become tricky, and you start to balance the different sensory systems that they're seeking, or the sensory systems that they're seeking. That's a lot of S's. Because it may be that they're wanting more vestibular input, but yet that could actually have a really adverse effect on the head injury. Whereas if they're more of a tactile seeker, it wouldn't be. And that tends to change throughout the day and in different situations. So the ADHD, students with ADHD are a little trickier because you've got the sensory system, you've got the behaviors, and now you've got the head injury on top of it.
Anything else? Okay. So I was hoping that each of our panelists could potentially share a story of someone that they've worked with at whatever type of brain injury that may be, and how your specific position or your team worked with that individual to progress in their treatment.
I'm going to force you to start on that.
Trying to pick one. I worked with a 9-year-old who had a brain tumor, and he was extremely sociable, popular guy at school. Everybody loved him. And the part of the brain that the tumor was on left, even though it was removed and it was a successful surgery, it left some effects that battled with his short-term memory. He battled with that feeling hunger. He never remembered that he had ate, and then was always hungry. He never had that. He had an insatiable appetite after that. And he also had a little bit of what looked like stroke-like symptoms, a little bit of sagging on the left side of his face, and his arm wasn't as effective with his fine motor skills after that. Again, I typically work with the children in the beginning of their phases with TBI. So a big part of that was his self-esteem and body image issues. Then also integrating him back into the school system, helping his community understand where he was and help them meet him there with some of the deficits that he was experiencing at that time. So it takes a team effort. I think that's the big part, is to have the collaborative to make it a family-centered approach, keep his self-esteem and motivation effective so that he wants to continue with therapies, and then also giving him the courage to go back to school when things are very different than when he left school. So that was a challenging case that I was honored to work with. He was also a big brother, and he took that role with great pride and felt, I think he struggled with that aspect the most. It was like, is he going to still be able to be a big brother and take care of his sister like he had up until that point? So just kind of seeing where your child's wants and wishes are may be different than what staff or parents are saying, oh, well, we're okay if he proves this checklist, A, B, and C, he does that, so he'll be fine. But his biggest concern was being big brother, and was he going to be able to fulfill that role? So making sure we take care of their wishes as well as on their journey through healing.
One of the biggest, most memorable success stories from one of my patients was a young lady who had complications from an oral surgery and ended up with a bad anoxic brain injury, so a lack of oxygen to her brain for a sustained period of time, and she was in the ICU for a very long time, and our therapy team worked with her for several weeks. When she left us to go to inpatient rehab, we were working on things like helping her to hold her head up on her own. She was sitting in a wheelchair with support. She was working very hard to reach for a cone and knock it over using big gross movements without very much precision. She had a lot of high muscle tone, so she had very tight muscles. It was hard for her to move. And she went to rehab, and her mother called and gave us an update a year after her injury, and she was back in school and reading and writing, and had gone on vacation with her family in Hawaii and decided that her ankle brace didn't feel great in the sand, so they didn't use it. And since that time, she hadn't used it at all, and she skied 8 times last winter and was back to school with her twin sister. Really amazing. So, and then I think the other success stories are the less dramatic things. The kids and the coaches that are educated and responsible, and the high school or rec coach says, I don't think that kid looks quite right, and pulls them out, and it's a non-event because people say, yeah, I don't think that's the right time to keep playing. And the kid says, yeah, I don't feel very good. I'm not gonna fake it and go back into this game because I wanna play the next game or the game after that. And I think we're doing a lot better job about educating coaches and athletes on the importance of not minimizing symptoms so that they can continue to do the things that they like to do and don't have to have big lifestyle changes because they've had repetitive head injuries. So I think those are the real head injury success stories.
One of the most impactful stories was we had a 14-year-old who was involved in a car accident. And I can't remember the details of the insurance, but basically she couldn't stay at the hospital any longer. And our physiatrist really advocated hard to get her into rehab. They didn't want to send her to a nursing home. She was 14. They really wanted to send her to rehab. And our team walked into the room, and it literally was an ICU room. I mean, she barely had any eye opening. She was thrashing, couldn't sustain a gaze. I mean, she couldn't look at any one place. Her eyes were all over the place. And we all just looked at each other like, wow, what are we supposed to do? You know, we're a rehab facility. And but her parents and the doc was like, we got to give her a shot. We just have to give her a shot. And she stayed for many, many months. This was back when you could do that. So 3 or 4 months she was with us, and she went from literally barely being able to open her eyes to, seriously, it still chokes me up. And this has been since I started, so many, many teen years ago, tons of years ago. Her goal was to walk out on her dad's arm, and she did. And she came back probably about 10 years later. She came back, and she'd won, for high school, she had won a one-man speech competition. And she was nonverbal and had a trach for the majority of her stay with us. And then she went on and became a physical therapist. So it was huge. It was absolutely, and this was a girl that we looked at and we were like, there's no way that we're gonna be able to get her anywhere. But it was her own, she fought hard every single day. Her parents fought. She had a huge support system, and she never gave up, and neither did her family. So it was a huge lesson to us too, that we don't look at where they're starting, and that's never an indicator of their outcome. She was a fighter.
Well, to create some diversity, I saw a mild brain injury case. A young lady was 17 when she got referred to us and had been a cheerleader. And who knew? Concussions in cheerleaders are rampant. And she had sustained a series of falls, but the most significant, she fell off a pyramid and hit the back of her head. And that was the one where she felt like symptoms were just sticking around. She wasn't totally getting better. And mom was so dedicated to fighting and got her into the concussion clinic and got her evaluated. And she came in and saw us, and we did a battery of tests. And I think that one of the biggest reasons that in my mind she was successful was the amount of flexibility that her and the family were able to demonstrate. And through the process, we identified some mild difficulties, and she had had a series of injuries. So that 3-month mark being totally symptom-free was a little bit more questionable for her. And so what she decided was, you know what, maybe going back to cheerleading isn't the right thing, but I'm going to coach. And staying involved, stayed really socially active. Again, worked really closely with mom, got accommodations in the school, and was incredibly successful. On the last that I had heard, she had been denied accommodations for the SAT because she was doing so darn well, and was on her way to college and just doing incredibly well. And I think of that as being a success, not only in terms of getting what she needed to thrive, but also looking at life a little bit different way and having that flexibility to live her best possible life in spite of having something that maybe changed the way that she viewed the world a little bit.
I think all these stories just demonstrate one thing that we know working with kids is that kids are really resilient and they have amazing capacities to recover after significant injuries. And I think we get surprised by those kinds of things all the time, and it's a great surprise. So one teenager that I worked with who had had some concussions, and I think he played football. The most recent concussion, he had kind of followed the doctor's orders and I think just got a little overzealous with them. His family was keeping him in his room in the dark because they were told that it needed to be not too stimulating. He was not really allowed to do much, so he was basically just sitting in a dark room. And I think he had been doing that for a week or a week and a half, and he came to us and he said, you know, my symptoms just aren't getting better. I still feel headachy and dizzy and all these kinds of things. And so there's a literature-supported, published, kind of what we call return to play, or basically return to life protocol that allows a stepwise progression of what to do and things to look for or watch for as you progress after a brain injury. And so we implemented this young man on that and said, all right, here's kind of your tasks going forward. I don't want you to jump back into doing everything, because he hadn't even gone back to school. He was just staying home, again, in a dark room, feeling terrible, understandably. And so we worked on just very slowly kind of progressing him through this stage after stage, just starting off with, okay, first you're just going to start off, doing your usual things around the house, going up and down the stairs, getting dressed in the morning, again, implementing a routine, getting back to that structure. And if you notice that you're starting to get worse symptoms or you're starting to feel bad, take a break, sit down, and then get back to it after a few minutes once you start feeling better. And he was able to progress through that, thankfully. And after we saw him back in clinic and follow-up a few months later, he had been able to get back to school. He was not yet back to playing football, but otherwise had really returned to all normal aspects of his life, which I was really happy about because he wasn't having symptoms, and this wasn't something that ended up really ruling the rest of his school year, if nothing else. It was a little bump, but I think we got him over it. And so that was really encouraging to me, just because I felt like we were able to give him back a part of kind of his daily life and activity that had really been taken from him after this brain injury.
Thank you for sharing. I want to open up questions to the audience. Anything that you may want to ask our panelists that we may not have covered, or even that we did cover. There's a microphone right up behind you.
Hello. Jim and Megan Andrews, and our son had a serious traumatic brain injury 2 years ago. It was very similar to the surgery, the air embolism during an open heart surgery. Okay. So he's a miracle today. If you saw him, you wouldn't necessarily pick up that there's anything going on, but there's a lot going on. And I guess my question really is, we're 2 years out now. And, the first year was complete recovery. The second year, we had him in probably at least 13 different therapies a week. And he was so done with it by the beginning of this year that we've just put him in school and slowly trying, but the academics are so hard for him. And really my question is, now after 2 years, not that this is as good as it gets, because he's still 11, so obviously he's going to continue to learn, but will some of those things get easier, or we really are we at the now we just need to focus on the accommodations? Does the question make sense at all?
Yeah, absolutely. I'm going to preliminarily answer that, and then I'm going to pass it to the people that address a lot of this in a day-to-day. I think one of your questions is this it? Like, are you plateaued? And I would say from a recovery standpoint, when we traditionally look at recovery after brain injuries, we do see that the trajectory or the slope of recovery slows down dramatically, particularly after the first year or two. Do I think he's done recovering? No. Do I think he's done being able to learn new compensatory strategies? Definitely not. And so I think that it's totally understandable that a kid could get burned out on therapy, especially when he's been doing it for the past 2 years, basically now. But I think sometimes one of the things that we look at is, okay, what compensatory strategies can we set up in school so that he's still being able to learn and keep up with his peers from a cognitive standpoint, and then from a therapy standpoint, you can schedule little check-in visits. Maybe go have him see the physical therapist 3 months from now, 6 months from now, and it doesn't have to be this thing that he feels like for the rest of his life he's got to see a therapist 2 or 3 times a week.
Yeah, and when you talk about learning compensatory strategies, I think sometimes that can feel like torture to kids. They think about it and they think, oh, you just want me to do math problems. But I tend to find that if you can find a way to break how to solve problems down for kids, they can apply it to a whole lot of different things. And so sitting down with somebody who is creative, who has a really good sense of your son's strengths and what is more difficult for him with something that he loves, and helping him figure out how to problem solve through something that he actually enjoys and is motivated to get the skills down and to practice them, he's then much more likely to be able to generalize that to this whole plethora of other things that he has to get through. But it can be really easy because we want so desperately for kids to be successful that we focus on the things they need to be successful. And so sometimes taking that step back approach and finding somebody who he clicks with and who gets him, and picking a task that he enjoys and allowing that to set the rhythm for his new approach to other tasks can be a way at that 2-year mark to make sure that he's continuing with that new learning, because that's where a lot of his continued gains are going to come from, and that he feels like he's part of it, and it's fun, and it's about something that matters to him, because that can really energize.
And how often he had the full neuropsychological evaluation done 6 months post-injury?
Mm-hmm.
And it's been 1.5 years now. When would you suggest another one?
I think this is a fine time to request an updated. 6 months to a year, you still see a fair amount of change, especially at this 1.5 years. I think it's absolutely valid to say I'd like to have a new sense. And that person, if you find someone, again, who he really gels with, or it can be a therapist who's a really good fit for him, but using that information to help plan a new way forward and not necessarily spending the time on therapy tasks, but again, applying it in a way that feels meaningful to him.
And I think sometimes too, when kids, when we were talking about scaffolding, when kids learn a skill, we want to build on that and continue to build and continue to build. And sometimes that load can get pretty heavy for kids. So sometimes taking away some of those things that we know they already know, and they don't necessarily have to continue to carry with them. For instance, writing things down, having a visual sequence of things. So I don't have to use my brain capacity all the time to remember what comes next or in what order to do something, but let me just write it down. Let me make a chart so I can use that space for new learning, for new things, and then slowly reintroduce those things, back into the routine can also really help to be that kind of support. We don't have to carry 8 bags of groceries in, at once. We can make multiple trips. So just taking some of that load off so we can make room for new learning and new space can also be really helpful and a lot less stressful for them too.
And I think periodic or episodes of therapy is a great approach because kids get burned out and they don't feel like they're getting something out of it if they're going and working on the same things week after week after week. They get bored, and that's totally understandable. So taking a 12-week session and saying, what are your goals? What are your son's goals? What are activities that he is struggling with that are really important to him to work on? And doing that with a therapist for a while, and then taking a break to practice those things and use them in functional situations and have fun with friends and not have your entire lives be occupied by driving to appointments. and then going back and saying, okay, well, these things have been going okay, but now we would really like to work on these few specific functional skills for a while, and making sure that the things that the therapist is incorporating into their treatment plan are things that are meaningful to you as a family.
Are there any other questions? Going once, going twice.
I've got a take-home points slide.
Go for it.
I really like PowerPoint. I can't help it. You can just click through some stuff, because a lot of it we've already talked about. And there's only like 6 or 7 slides, I promise. This is not going to be that bad. Oh, this is just how we evaluate brain injury. One of the things we were talking about, detecting brain injury, it can be really hard. There's a lot of ways to evaluate. There's clinical exams, there's imaging. This is something called the SCAT-5. It started off with the SCAT, and then there was the 2, 3, 4. This is the 5th iteration of a sideline exam. So if you have athletic trainers or coaches in the family, they're going to be familiar with this. You can see, so this is only 2 of like the 4 pages of this exam. So it's pretty comprehensive. This is what, whenever the NFL has that tent on the sidelines where they're going in and evaluating the players for a possible concussion, this is some of the stuff they're looking at there too. Keep going. This is generally to say, if you think your kid has a brain injury, they probably don't need imaging, and there's a whole algorithm for it, but that's kind of where I'll leave it. Most kids, imaging is not without risks. Radiation is real. You can find lots of things that may need follow-up that really weren't anything there to begin with, or asymptomatic things. So just trust that generally, unless your child is very much acting different from how they normally are, or something totally new has happened, they probably don't need imaging.
We have a question.
Oh yeah, what's up?
Okay, so, I don't know if this is working. So as I kind of picked up, so you guys were saying that there aren't a lot of long-term effects from after a concussion occurs, usually that 3-month mark. So a lot of times in sports, when concussions keep reoccurring, the head braces get put on or they get pulled from the sports. Do those symptoms just kind of accumulate until, I guess just why is that, is what I'm asking.
Yeah, so at kind of a cellular level, when you have a concussion in your brain, it changes kind of the chemicals in your brain, and it changes how the brain cells work, or how they don't work. And so one of the things that I am most concerned about as a physician is something called second impact syndrome, which is where a person has a brain injury, or excuse me, a concussion, and it's not fully healed. And generally this is like a same game thing, where they go out again and they have another head injury or concussion, and it kind of is additive and even can be exponential. So then rather than just having a little bit of bruising or something that you might not notice long term, that bruising or swelling in the brain can become critical and can really cause serious issues down the line. Washington is a really excellent state in that we have something called the Zachary-Lystedt Law. It's named for a kid who was playing football and had second impact syndrome, and as a result was left in a wheelchair and has significant disabilities because he was playing football, had a concussion that was not recognized, went back out on the field, had a worse concussion, and then had a very severe brain injury after it. So the Zach-Lystedt Law is in place to help provide support both to coaches and athletic trainers and schools to really be mindful of concussions and to watch for that, which I think why, one of the great things for us as providers is that we see more and more, like Erin mentioned, kids are getting recognized. You are not acting right. You might have a concussion. You're out. There's no going back in. There's no, oh, but this is the championship game type of thing. And so a lot of the cumulative effects just have to do at kind of a cellular level with what's going on with a brain that's just been injured. And then it, unfortunately, can just get super exponentially cumulative really, really quickly.
And even if it's not that exponential, that over time, if you're having concussion every week for a series of seasons, that your ability to recover back to your baseline and live your most meaningful life can start to degrade. And so that's why there is a point at which, if you've had a series of injuries, they may be looking at, like the case I was mentioning, no more going up on the pyramid. Let's keep you in sports, let's keep you socially engaged, but can we do it in a way that's going to be more protective? You are so young, you've got so much ahead of you. So keeping that mind on, and that's where that comes from, is because even if it's not that astronomical cumulative, over time, repeated exposure, there can be some cumulative effects that we want to be mindful and protective of.
Definitely, definitely.
And as a parent or caregiver of children who are potentially in situations like sports where they may have concussions, one of the things that I'm always telling parents about when I see their children in the hospital with concussion is that if they've had repeated injuries, like we've already said multiple times, people in general recover from concussions and have no further ongoing deficits after that 3-month period of time. But if you're having repeated injuries and your symptoms are worsening with a lower level of impact, that's when we start to think, should we maybe change your activities? Do you need to switch from soccer to cross country? That you get more symptomatic with a less traumatic event is a big factor. So if that's something that's like, it didn't really seem like they had a big thing going on. They bumped into another kid in a soccer game, and I don't think they hit their head, but they're really dizzy and nauseous and have had a headache for the last 3 days. That would be worth a discussion with your primary care doctor and pediatrician.
Yeah, definitely. Sorry, was there another question? Yeah, go ahead.
That second injury will lead to chronic traumatic encephalopathy.
So, yeah, great question. So the question was, does the second impact syndrome or those cumulative injuries relate to chronic traumatic encephalopathy, which is something that's gotten a lot of press lately, particularly because it's been something that's been studied mostly in NFL players. For the majority of people, I generally say unless your kid or you are playing NFL level football and that frequency for that amount of time, because that's what it's been studied in. It hasn't been diagnosed in anyone who's not been playing in the NFL and having those hits week after week for many, many years. It's less of a concern. It's hard to say, did those changes over a cumulative amount of time, is that what contributed to it? Is there something else at play? I think it's something that we have recognized as a thing, but we still don't quite have all the whys behind it. But generally, I reassure parents that, again, unless your kid is playing a massive amount of really high collision sports, it's less of a concern. That being said, it's perfectly reasonable to say a sport where you're crashing into other people all the time as one of the end goals maybe is not the safest, and we could consider cross country or golf or something. So
Actually, I had a parent who had her son play golf because she was worried about the contact sport. And I saw him 3 times in acute rehab for a head injury from golf, 2 balls and a golf club. And she was like, I'm done
So
with
chess
sports.
team, math leads.
Yeah. Yeah. She was like, this didn't work for me.
Oh my gosh, yeah, sure. Question in the back?
Yeah, we ready?
Okay.
Okay, I have a question I'm going to try and be concise on. I'm good at insulting people, but I want them to understand. I want help. Are you guys helping children get to support groups? I love my support groups I attend. I find myself included, as survivors, we have experience with ourselves, and we try to give advice to each other, which is terrible. And our parents that have experienced the terrible experience they have to go through, it's tough on them, and they'll think, okay, I have experience with my child, so I can give other people advice. You who have orders of magnitude more experience probably understand how little you really know generally about everybody. Do you direct your patients to support groups, and then do you reach out and work with these support groups to help educate them? Yeah, I think that's my question, and I'm hoping this question will help other people keep in mind that support groups are out there, and they're helpful, but the support groups need help from you.
great question. I saw Dr. Hedgie deeply nodding there.
Absolutely. That's something I talk with families about all the time, and especially in terms of caregiver stress and normalizing and recognizing that looking for strategies does not stop when you leave the hospital or when you leave therapy. It's an ongoing thing, and that there are people that have more experience and more creativity in coming up with ways to manage than we do. So absolutely, that's something I talk with patients about a lot.
Do you all have support group references or resources?
I say I'm fairly new to Spokane, so I'm still learning the support groups in this region. But I think that's a very big factor. We try to drive home with families is identifying what their support group is, not only as a organized group, but whether it's church, school, neighborhood, helping them find their support systems is a very big factor, and we try to help the family navigate that.
I think that's one of the real great things about having the internet is that you can find a support system through social media, through online forums, particularly for sometimes, we take care of patients who have rarer diagnoses or things that may not be as common causes of brain injury, and so then being able to direct them to even online resources can be helpful. But yeah, no, great question. I mean, support groups are definitely important. I agree.
And we want to support them. So
Yes.
if there are things that we can be doing to support the local support groups here, please let the organizations that are here, or any of us know, because we do want to support those groups and make sure that they're functioning the best way and supporting people in a way that's actually moving people forward and not getting stuck or getting chaotic.
Yeah, definitely.
I'd like to point out in the brain injury community, there are a wide range of types of support groups. So we have caregiver and family support groups, we have survivor care groups, support groups, we have mixed integrated groups, there's social groups. I mean, there's groups for a wide range of different supports that you may need, and there are other survivors, there are other families that are similar. So if you do want to connect with a support group or learn more, there's some information in your packets. You can also talk to any of the organizations here about different types of support groups that may be offered. Are there any other questions? Okay. I want to thank everyone for attending the panel, thank the panelists for all the help and information. I have a few announcements. The first announcement is there is coffee, hot chocolate, tea, apple cider, and lots of cupcakes. So go enjoy them, take some home, do whatever, they're for you. There's also, I want to let you guys know that there is the TBI conference is coming to Spokane for the first time ever, and it's going to be held April 15th through 16th, this in 2019, at the Doubletree Hotel in downtown Spokane. Presentations are going to include vision therapy, yoga for TBI survivors, concussion protocols, independent living, and much more. If you're interested in more information, there is a flyer in your packet as well. You can contact Tammy Olson, and you'll find her email in there. I also would like to say that we love putting on these events for you, and we encourage any ideas, support, whatever that may be. If you're able to, you can donate to us today at the back table, and we would be able to generate more events in the future. And last but not least, we're going to do the drawing for the door prize in about 5 to 10 minutes, so stick around to find out about that. But if you have any questions, you can ask our panelists after. I encourage you to talk to our different resources that are here because they are really great outlets for individuals with any brain injury. So thank you again.